All right, so we're going to get the program started, and I think first up is Dr. Hance Clarke, who's going to provide an overview of the past 10 years of TPS. I've known Hance for many years now. He's the director of our pain services, the Good Hope Ehlers-Danlos Clinic, and the Pain Research Unit at Toronto General Hospital. He's a Knowledge Translation Chair for the University of Toronto Centre for the Study of Pain and Associate Professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto, and holds the Good Hope Ehlers-Danlos Chair in Translational Medicine. He's not a full professor yet because he just hasn't put his paperwork in. Otherwise, he more than deserves to be a full professor. He's authored over 180 peer-reviewed publications and has been invited to speak on pain control, cannabis, and the opioid crisis to the House of Commons in Ottawa, Canada, and elsewhere around the world. He's currently the president-elect of the Canadian Pain Society and the president of the Canadian Consortium for the Investigation of Cannabinoids. So, Hance, please.
All right, well, thank you very much. It's absolutely a privilege that you took time out of your day to spend this day with us here today, and I want to thank you very much for doing that. And what I hope to do is take you on a journey, based on where we started and where we are now. And before I do that, though, I will plug that next Monday we have our annual scientific meeting for the Canadian Pain Society. There is a specific congress organized by Health Canada with the Canadian Pain Society, and we will be discussing all sorts of things related to pain and the issues surrounding the 8 million people in Canada living with chronic pain. And so everything from the opioid crisis to the use of cannabinoids to research funding, and really looking at what we're doing based on what has been done in the past, turning the page, and how we're going to move things forward nationally. And so we're a small part of the ecosystem, but looking forward to some really big things ahead. And so this is where we started. So we know that chronic post-surgical pain is an issue for 15 to 20% of the individuals that come into our operating rooms and walk out the other side. And it was pretty clear that, my PhD supervisor, Joel Katz, who had done decades of research in this area, that we were studying a very complex problem in a very simplistic way. And so, we were asking patients 6 months out, do you have pain, yes or no? What's that number? And based on that, we were coming up with numbers that 70% of individuals could potentially go on to be living with chronic post-surgical pain. But something didn't seem right. That was a very simplistic way to look at such a big problem. And what we needed to do was start to look at this prospectively and figure out what that number actually is. And what we do know is that if you have a surgical intervention, and you're one of those two, it's probably 300 million surgeries now happening annually in the world, 8% of those individuals go on to have some type of disability as a consequence of their surgical intervention. And so if you multiply that year over year, you see what that number could become over time. And so when you look at the potential risk factors that we knew existed, so we know that if you have pain and you are a chronic pain patient, the likelihood that you will go on to have worsening of that pain or doubling of your opioid consumption, it was pretty clear. You'd walk into an institution and you'd walk out on 2 times the dose you walked into, and then the system was somewhat failing you at that point in time. We know if you have a worse outcome in terms of acute postoperative pain, you have the unfortunate scenario of potentially going on to have disability and worsening pain long term. If you were younger, if you were a woman, if you used more analgesics in the perioperative period, these were all risk factors that set you up for not doing well. If you had more invasive surgery, if you had numbers of chest tubes, all of these things we do to individuals to keep them safe and get them to the other side became predictors of who went on to have a problem. But what we didn't have was a program trying to intervene and trying to prevent or trying to actually catch this gap of this patient who's struggling before they develop chronic pain. And so I'll walk you through what that journey might have looked like in 2012. You come in, you have an operation, you see your surgeon 6 weeks later, they did a fantastic job, and you walk out of the office. And you didn't even talk about maybe some of the disability you were having, but you're now still taking some of these opioids that you were started on because you have a pain problem. You then see your family physician who says, oh, well, why are you still on these things, and what's going on here? Well, maybe we should send you to a tertiary care pain center. And that pain center gets the referral, and they see you maybe 16 months later, sorry. And so think about being 2 years, having an intervention, now being put on a medication and seeing a specialist that probably could have treated you earlier if you had the opportunity to be seen. And so that's the gap that we identified, and that's the gap we tried to fill. And so when you think about people that go on to have things like total knee arthroplasty, this was one of the top 10 publications in pain in 2015, and Gabrielle Paget, the first author, is now our scientific chair of the Canadian Pain Society. And I can tell you that most patients go on to do well. At 1 year, their pain is better, their function is improved, but you could pick out, if you look at that top line, the individuals that you saw before surgery at baseline that were probably not going to do well. And those are individuals with high anxiety, with significant pain catastrophizing. It's a term we don't like, but it's people that ruminate about their scenario, about their pain. These folks are set up not for success. And you can hear in the orthopedic literature that the surgeons are now talking about maybe not operating on these people. So I have a better idea. Why don't we build systems to identify these people and help them deal with some of these constructs before they land in the operating room? And so certainly some of the things we're doing and thinking about. And this is some data from my colleague in the back you'll hear from later, who's Dr. Latta, who's now back at the Toronto Western Hospital. And when we write grants and we talk to people about changing the system, what we want to do is say it's the greatest thing since sliced bread and we're going to change the system for everyone and this is what we all must do. But it's such a mistake because the entire system ain't ever broke. Parts of the system are broken. And what this clearly shows you is if you walk into the hospital and you're not on an opioid, or if you're less than 50 milligrams of an opioid, you're not going to have a postoperative overdose 90 days out. But if you walk in the hospital already taking 50 milligrams or higher, or 100 milligrams, your risk goes from almost 0 to 142 per 100,000. And so there you have it. That's the population you want to study, and that's the population you want to pick out and figure out how you're going to help them. So as Kayvan said, 2013, the Ministry of Health put out a demonstration project, and the call was pretty clear. How do we help improve the care for complex patients? They didn't say what type of complex patients, just complex patients. And I said, you show me a more complex individual than someone who has a chronic pain issue, potentially taking an opioid, coming in, having surgery, and then sitting there when you devote all the resources to them to get them to that point and then send them out the institution. And we were lucky enough to be awarded the funding, and we had 1 year of funding. We spread it over 2 with the help of the department and Salim and all of our acute pain team. And we went on to eventually get funding to move this forward. At the same time, TAPME was being created, and it was rolled into a bigger bundle for the province. And we get our little snippet, but we do well with our little snippet of funding that we get. And we're very happy to have that funding and continue forward. And so if you look at this diagram, when we started, no one knew what we were doing. No one had a clue what they were taught. What is this? And the best was, my patients have pain after surgery. These would be our surgical colleagues. How? What? Why? And then, sure enough, over the next couple of years, we went from, at the time it was Dr. Jerry O'Leary was our chair, and they were saying, well, where are these patients that you claim are going to come? And, we weren't seeing enough patients, et cetera. And then over time, people started to understand, holy smokes, look at the outcomes that these patients are having if it's identified early. People like Rosa Kim in the PR department were saying, look at all these folks that are saying all of these things, and then it spurred forward. So what we tried to identify early on were individuals in the acute pain setting that were clearly having intense pain, using a lot of opioids, having significant distress. And what you start to realize is there are other compounding factors in addition to surgical factors that play into how these folks are doing and why some of their outcomes are poor. And eventually, we moved it into the post-op setting. We're getting regular referrals from the surgeons as patients are now struggling with their pain or their opioid use based on how they present. And now we can see patients preoperatively. So the transplant group here at TGH, which is obviously one of our major interventions, transplant and cardiac are probably the 2 biggest, as well as cancer, 3 biggest. And they'll send some of these folks because we know that if you go in to have a transplant and you're on an opioid or you have a chronic pain history, your outcomes are actually going to be significantly poorer than those who don't have those types of issues a priori. And it's a very easy concept. So Chris Hayes, an anesthesiologist out of Australia, in 2003 published a very simplistic paper. It was, I walked around on my acute pain service rounds, and he asked, how many of you have neuropathic pain symptoms? Talking about that burning, that stabbing, that electric shock-like symptom. If your patient has that within the first 72 hours, and they have that beyond those 72 hours, there is an 80% chance they're going to have that 6 months later. And so you have a captive audience in that time, and if you ask, they will tell. And if they tell, you should intervene. And so that was kind of the nidus of how we moved forward. This is an awesome slide Joel pulled off for me last Friday. And so this was our roadmap paper that we published in 2014. So there have been 41,000 views, and the recent number as of yesterday, according to Joel, is 6,000. So maybe 50 of you did the extra 50 to download it, over 6,000. So again, clearly an impact. This is something that we can be very proud of. And so what's new? So it's another pain program. There's a lot of pain programs in the country. And what was new is we brought back the intersection of physical pain and mental health. And you'll see that one of the patients one of the individuals on the panel this week is, is Aristotle Voinescos. Aristotle is the VP of Research at CAMH. CAMH and UHN are now talking about integrating the mental health and the physical health space. And so there are going to be some big opportunities for us to not just talk about this as separate institutions, but bring these silos together and build programs as we move forward. So stick around for that panel discussion at the end of the day. It's obvious that we do the easiest part of this as physicians. I can give you pills, I can put needles in specific places, I can give you some local anesthetics and steroids, things like that. But the hardest part is having engagement from the patient who now realizes they're in distress. And we've really failed if a patient lands in one of our post-op clinics, if they say when they sit down, I never knew this was a possibility. So someone has cut you open, they have sewn you back together, and this is the first time you're encountering the fact that you may develop some type of a pain issue as a consequence of that. It's not common, but it's a possibility. And we have to start educating patients well in advance to help minimize some of that distress after, because it's something that they were informed about was a possibility. Not a foregone conclusion, but a possibility. And so take that distress, bring that together in the clinic, bring in the psychology team, and start to talk about acceptance and working with this. And yes, I always say the beauty we have is that possibility to prevent. But if we can't prevent, we can at least change the trajectory of that disability. And it remains to be seen whether, and Joel and I always talk about this, can we actually prevent chronic pain? Well, we're going to try. But if not, we'll at least help these patients on their journey. And so that was the big difference in terms of what we were doing. I'm just going to show you this paper. This was, we took the first cohort of patients that came through the clinic. And we basically divided patients, and we created the program, and one of my babies is I didn't build this program to be an opioid stewardship program. It just happened. It landed in the middle of the opioid crisis, and this was something that we realized there were a lot of fingers pointing at us as physicians in terms of our prescribing practices, and the perioperative space was one of those spaces that individuals were really getting called out for in terms of handing out 100 tablets and sending people home, and then they're there for diversion, et cetera. But what we built this program for was really to look at how do we identify early on people that are going to struggle and what do we do differently. So the two cohorts of patients were patients that were opioid naive, many of you in the audience, and those that had a chronic pain problem and were potentially on an opioid. And so I'm not going to spend too much time, but just give you the take-home message. If someone walks into an institution and they've never been on an opioid and you hand them an opioid, the number one predictive factor of whether they're going to be able to wean off of that opioid is the dose they walk out of the institution on. And so just keep some of that in mind. If you are an opioid experienced individual taking an opioid, and we know the numbers are typically are doubled, sometimes tripled for whatever reason, and to get you kind of moving from A to B, if you have a history of catastrophizing, if you have neuropathic pain, if you have a history of recreational substance use, those are all predictive factors, again, of you escalating and not being able to get back to your baseline. And there were no programs looking at this before we created this. And so clearly that was where we landed from an impact perspective. But then, of course, the biggest pushback I got was, oh yeah, great, Dr. Clarke, you're helping people wean your opioids and giving them psychological techniques to cope, et cetera, but their pain's going to be worse. Data's clear. The people that actually danced, weaned off of their opioids, had lower doses, had better pain intensity and lower pain interference long term because they started to live life again and they started to have an improved quality of life. And so what did this stimulate? So this stimulated discussions with, at that time, during the midst of the opioid crisis, guys like Eric Hoskins and Peter Pisters, and that's one of our patients, Norm, he's no longer with us, he was a fantastic advocate for us, talking about this response to the opioid crisis and what the perioperative space was going to do. And so I had the fortunate opportunity of being placed on some of these task forces looking at mortality data across the province. Tara Gomes is going to talk to you this morning about that journey in terms of the opioid crisis and what Ontario has done and are still trying to do from an opioid prescribing perspective. And I can tell you that what was interesting, people who were taking things like buprenorphine or opioid agonist therapies, we couldn't find them dead. And so there was something about some of these molecules, and OAT treatment, opioid agonist treatment in particular, that had this protective effect. And so this was a Health Quality Ontario document. That's Dr. Fine. Dr. Fine was also a patient of ours in the Transitional Pain Clinic. He's a medical oncologist. He was a cancer patient and developed a significant opioid use issue and was able to be weaned off and is doing very well, and also done some significant speaking around just the, opioids on his medical journey and how he was able to move forward. But this was data that stimulated a lot of attention. And so if you look at people who are started on their opioid journey, and if you're a family physician, as you would expect that they are the bigger prescribers of opioids. They're seeing the patients at that frontline level. But the next two rows there are pretty interesting. So our surgical colleagues are starting individuals that have never been on an opioid about 56% of the time of the patients across the province. And then look at the dentists. And so the dentists are starting almost 74% of the patients they see who have never taken an opioid on an opioid. And so what are we doing then in terms of following these folks and looking at outcomes? And so this has stimulated the dentists. I just presented to them in terms of some of the new prescribing guidelines we've put out, and I'll get into those a little bit. But this was kind of a shocking statistic for many people. And when you think about the dentists, they're dealing with that young population that are coming in, they're taking out their molars, and the highest risk individual we know is a young male. A young male, you start them on an opioid, they're going to be a tricky population to deal with if they really like these things. And so this is something we teamed up with the best practices of surgery folks in and around as a consequence of actually that slide, believe it or not. And we asked a very simple question to the entire surgical community. Do you feel adequately educated to prescribe pain medications, including opioids, to surgical patients at discharge? And the answer was pretty clear. The surgeons said, we have no clue, can you help us? The trainees and residents said, oh yeah, we're good, we got this. And so their bosses don't know, but if you make the bosses happy, we're good. And so I'll share a story with you. I was at the Euro Cup in France, and we ran into a group, it was 5 general surgery PGY5s who had just passed their exams, and we were having a glass of wine in Bordeaux or wherever we were, and I said to them, I said, so wait, you guys just graduated, so you're done. And we had just started, we're 2 years into this transitional pain program, so I was kind of a little bit aggressive with them. So what are you going to do? So you're going to have these patients, and they're going to be complex, and they're going to be asking you for opioids, and we're just going to give them whatever they want so they can get out of here, and give them a boatload. And I was like, oh yeah, that's a good plan. That's a good plan. And so anyway, this is the thing. And so, once we got the answer like this, we knew, well, we needed to do something. And so what did we do? We created a consensus guideline with the best practices of surgery folks here at the University of Toronto. They sent out a survey to all the departments, all the surgeons, and asked not which of your patients are going to have the most pain. Pain is not the focus. I don't ask people for a number. I'll say, is it mild, moderate, or severe? We ask them, in terms of recovery, is this going to be a surgery where you expect them to be back to baseline within 3 to 5 days, within a couple of weeks, or within a month or more? And so are you an immediate recovery type surgical intervention, a moderate recovery, or a long-term type intervention? And clearly, the orthopedic total knees would be a long-term type operation. A day surgery where you're coming in for a lumpectomy would be an immediate recovery type scenario. So we talked about that typical prescription, which was the norm 5 years ago, which is to hand out 50 Percocets or 100 Percocets or whatever your drug of choice is, so that the patient has enough of them, and they might use 4 or 3 or whatever that is. And Sanjo's got some great data he's going to speak to you about some of his interventions that he did at North York General. And so the premise of these guidelines or consensus statements were, 1, patient education, again, going back to give patients some control, give them some understanding of what they're about to do. 2, look at the risk factors. So do they fall into those categories of individuals that are going to be high risk for going on to have a problem? And modifying your discharge practices and following up in terms of if they do become a persistent opioid patient or someone with a pain problem, that we have a recourse for them. And I can tell you that it was a pretty simple guideline that was put out. Send everybody home on Tylenol, send everybody home on their NSAID. Their first 72 hours, the inflammatory processes are very mediated by, can be very, very much mediated by the use of non-steroidal anti-inflammatories, as long as you can tolerate them. And lo and behold, if someone's having a rapid recovery type intervention, you probably don't need more than 12 opioid-containing tablets. If you're doing a moderate type intervention, maybe 30. And for a long term, we can start with 60. 60, we all agreed, was a reasonable number, but here's the kicker. Part fill it. Something we do in the community all the time, something we do in the chronic pain setting all the time. Give somebody 30. In a week, if they still need the other 30, they can go back and get it, and your prescription expires in 60 days or 30 days, whatever you want. And so no one's going to have these surplus that people have been seeking and sitting there. And so from a diversion perspective, I think we've done our due course. If you look at the date of that publication, it was the day before Canada locked down. I don't think anybody has seen this in the past 3 or 4 years, but we did a significant stimulus of what we're doing today, disseminating to the surgeons, and so there's no doubt we have made a dent, but I think this is something we could focus on disseminating even greater now in the coming years, now that we're out of COVID, and we could start to focus on some of these things. I'm just going to briefly touch on a couple of patients, and so the gentleman on I think it's your left, is Michael. Paul is the gentleman with the mic on his lapel. Michael was a gentleman who was started with a fibromyalgia diagnosis in the 90s. He was on massive doses of opioids because 30 years ago or 20 years ago, that's what we did. We started people on opioids for almost any pain problem. You wouldn't do that to a fibromyalgia patient. Now, developed a benzodiazepine dependence, et cetera, took his care into his own hands, perfed his esophagus, ended up being in our ICU, and they called us because they didn't know what to do with him. He was on so much fentanyl in terms of keeping him calm in the ICU. One of our very first patients, we spent a lot of time with him. He did quite well. He went on to have an operation. I see Des here at the East General on Suboxone, and to their credit, they didn't stop Suboxone, and that was a time where people were stopping these types of drugs before surgery, and we certainly have created some guidelines that I'll share with you. Paul's one of the toughest guys you'll ever meet. He's an Irish boxer. He's been around, and he's now got an entire back that's fused. He's struggling a little bit. His pain medication regimen, believe it or not, neither of these guys have ever gone to an illicit substance on the street, was 30 milligrams of hydromorphone subcutaneously injected every 2 hours. That's what we did as a pain community treating postoperative pain. And so he was at the point where his kids weren't bringing his grandchildren to see him anymore, and he was like, I'm checking out of this. And so somebody got a hold of sending him over to see us, and he was also on OAT and did very well. And so COVID really threw us for a loop. How do we treat these people with complex mental health issues, with dependence issues in the pain space? And we realized we couldn't stop treating people and moving them forward and putting them on opioid agonist treatment. I don't remember the last time I brought somebody in the hospital to do an opioid agonist treatment induction or a Suboxone induction, anything like that. And so we teamed up with the guys in Calgary, and we have a home induction protocol. So I always say to the patients, yeah, but we're going to be in withdrawal. I said, well, no, because you're going to talk to Max, and you're going to talk to Molly, and you're going to talk to Rachel, and they're going to give you some techniques to deal with that distress. Withdrawal is one of the most aversive states a human being can be in. And so they've got to have some tools to cope. And you're going to do this in your bedroom. We'll call you a few times that day. We'll make sure we reach out. We can do it via MS Teams, however you want to do this, but you don't have to leave your bedroom to get off of your opioids and move on to something that's more successful, and we continue to do that. I'm going to shift a little bit because we now have a kind of a medical cannabis academic clinic. And this is, one of the first, I think, that we were certainly one of the first when we started. There may be a couple others. McGill is obviously in this space as well. That's Calvin. He's one of our anesthesia residents. He's working with Kareem and Demindo over at St. Mike's. And we're going to present some of this data for the first time again next week at the Canadian Pain Society. But just something to tell you that this is a long-term study that we've been working on. We've just, the Shoppers has gotten out of this cannabis space, and a company, Avicanna, has taken that over. So we're just working on relaunching this. But we have a database already of about 300 individuals for about 6 months that have come through using cannabinoid products for either chronic pain, sleep, and anxiety. We've recently rolled epilepsy into this space, and we're going to continue to try to collect data moving forward. This is some cool stuff, and this is why I'm going to share it. So we were awarded a grant by CIHR, partnered with Arthritis Canada, And it was a 1.5 million grant over 5 years. And I just want to share with you some of the really cool things that are happening in Mohit's lab. Lakshmi Koch is a biochemist here, a drug discovery guy, and Tim LaRue is the surgeon that's really invested in this project with us. And this is oral consumption of high-dose THC. And if you look at the top where the sham animals are, and this is a DMM model. What that means is you basically disrupt one of their medial meniscus ligaments. It's a rapidly progressive OA type scenario. And take a look at the DMM model when you get to that 10 milligram per kilogram THC. And that little proteoglycan layer at the bone intersection where the femur and the tibia meet, there's a loss of those proteoglycans in the osteoclast. In the higher dose THC animals, it seems to be preserved. And if you look over at the synovium, which is the white part of that cartilage there, it's almost preserved in high-dose THC animals. And so this was pretty surprising. We've run this a couple of times. And then you look at the behavioral correlates over here, and if you look at the animals that are on the high-dose THC, you're almost seeing a behavioral response, and so some evidence there that there might be a disease-modifying effect of, guess what, THC. And what have patients been telling us for years? That there's something about this THC that helps my OA, that helps my shoulder pain, that helps all of these things. But this is going to be a pretty interesting story as it evolves forward. So we're making sure we replicate this. We're writing this up for some pretty high-end, impactful journals, and we'll see where we land with some of this stuff. We were also just awarded the ability to, we were just given the opportunity, we were partnered with McMaster to run a cannabis clinical trials network. And so we have some chronic pain RCTs happening. We're about to launch an osteoarthritis randomized controlled trial, and we have some work with restless leg syndrome. We're going to try to run out of UHN and try to support kind of this infrastructure as we move forward. So all of these are projects that opened up and stimulated from the start of the TPS and the SUAP funding and many of these things. Kareem was the lead author on this one, where we published some perioperative guidelines. ASRA has since done a secondary guideline after ours in terms of managing some of these things in the perioperative setting. So again, so many intersections with some of the work we're doing. Thayer Jan Mohammed will be here. He's a third party. He owns a company called Managing Life. He has an app called Manage My Pain. And I'll tell you that our patients are now providing data in the comfort of their own homes, okay? We don't give them the paper when they walk into the clinic anymore. They actually use the app, or they can do it at home. They get reminders. And we ask a lot about what they do and whether it mattered to you today. And that's the metric we're trying to move to in the pain space, away from fixing a number. And this was the only reason we landed here. We have COVID to thank for that. And so COVID rolls in, no one's allowed through the doors of the institution, we're seeing people by phone, we're seeing people on video, all data's lost, right? Well, no. We were lucky enough to have the opportunity to roll our database into this mobile space, and we kept our data rolling entirely through COVID, and patients were continuing to give us data and tell us how they were doing, et cetera. And so totally important stuff. And so I'm gonna tell you that to be a successful app in the world, do you know what your engagement rate needs to be? 30%. 30% is a blockbuster app. And so we rolled out this app in a 3-site study, 2 sites here at UHN, 1 site at Iroquois Falls, a large indigenous population that would come down and see docs after traveling hours to get down to Iroquois Falls. And it was clear that the data, we ran at Toronto Western, we ran at Toronto General, 30% engagement at best in this project. But at Iroquois Falls, what you saw was that there was a much higher engagement, because now you could actually communicate with your clinicians without having to travel for 8 hours, and there was a lot higher uptick in that. But that's not the kicker. The kicker is this. When people start to engage and start to give you data and start to self-manage and look at things and enter things, and they get their charts in terms of how they're doing, first data of its kind to show that a mobile app use reduced anxiety early on and reduced pain catastrophizing long term. And what's coming? So Max and crew and Anna and the team are working on digitalizing some of what we do in the clinic. And let's be clear, this system is so overstretched. We are never going to be able to do one-to-one care forever moving forward. You must have tools that your patients are engaging with. Group therapy is a key to treating our population as we move forward. And the patients are not going to like this, the society is not going to like this, but if you expect this small number of physicians to continue to treat the number of patients we have, one-on-one care is really in trouble. So it's just something to think about. Okay, So we're going to start to wrap up here. And, one of the things that we were doing, you've seen some of the publications that we've had in the space, et cetera, is that, okay, great, you guys are doing all this stuff, but what are you doing? And so one of the things that SUAP said to us was, if you're going to keep doing this and publish and show these outcomes, how are others going to replicate this? How are others going to be able to build something similarly in this type of a space? And so we were lucky enough, Anna's picture's there, she's done a lot of our web design and a lot of the tools that are out there. And I can tell you what they did was we actually put it online. We created a document and we posted it online, and it has been downloaded hundreds of times around the world, and there's been thousands of views of this website. And so we clearly have done something. And this is not just written for the physicians, it's written for your policymakers, it's written for your admins at the hospital, and just give you the tools to figure out what you need to do if you're going to build one of these services. And we often get visitors now coming to just see what we're doing and how we're moving things forward. We built some educational modules, chronic post-surgical pain models. These are on the TAPME website as well. TAPME is the hub that obviously the ministry funds and comes through to, our funding comes through from that. And again, focusing on the intersection of these three issues. We have a module on what is a transitional pain? So why do I need to know about this? And what's this concept of transitional pain? And the beauty of that term, it spans so many things. It can be, inpatient to outpatient care. It can be high-dose opioids to low-dose opioids. You can transition to so many areas. And so we do like our term. I won't touch on this. Jeff and Max are going to touch on this in the next session. But, how do you help people move forward while they're in distress with their pain and accept things and move things forward? Huge learning resource section on this. And so I think we've done our deliverable in terms of that knowledge dissemination. This is a recent paper that took a lot of time to figure this out. So we looked at the ISIS data set, so ISIS being the Institute of Clinical and Evaluative Sciences out of Sunnybrook, and we needed to start to look at the database and say, what is the TPS actually doing as we compare it to the rest of the province? We're like we were the singular home when we started. And we initially, because we really built this around collecting data and research, et cetera, got permission from our patients to do this. And so we looked across the province, and it's clear that what we are able to do is pick out those individuals that are using higher doses of opioids, and you can see our trajectory is pretty steep to bringing them back. And so some evidence that actually what we're doing might make sense. Now, the ultimate evidence is going to be randomized control trials. So no matter how much we talk about the great things that we do, there's some naysayers that still say, well, show us that there's an improvement. Show us that randomized control trial. And this is, the opioid pendulum was here. We swung it to here where you're not prescribing. We were a lot more successful early on, and then COVID hit. And we've been struggling to continue to recruit in this trial, but we're not giving up. We're going to finish this, and we're going to see what we have at the end of the day. And hopefully it will be in our space. Okay, so Graham is here. I know, where is he sitting? There he is. There's the man. So I'm going to share a story. I'm going to share a story about Graham. And you can see Graham's got an arm here that he had a motorcycle accident. All of his nerve roots from C5 to C8 were completely avulsed. So inability to use that arm. He was sent home after his operation, and they said, oh, it'll be fine. It'll get better. I think he spent about 6 months in bed, curled over. Years later, I didn't meet Graham until years later. He was going to have some cosmetic type surgeries, and the surgeon knew me and said, I think you need to go over to this clinic and see where you're at. So Graham and Sid's mom is here. Sid had a procedure. She couldn't make it today. She might be here a little bit later. Sid broke the record for the number of days in hospital at Toronto Western Hospital. She was there for 465 days. She is a patient with a diagnosis of EDS and struggled again with the journey through the hospital system. She went home, and I think I took over her opioid prescribing via CAD pump intravenously for a year, and Sid developed infective endocarditis, as we kind of predicted might happen. Came back to the general. Salima was involved in this case, as well as the entire psychological team, et cetera. And she believed in us and decided, okay, this was the moment in her life where maybe we're gonna move forward and try to change some things. And you'll see both of their stories as we move forward here. So I'm gonna play this, and then we're really gonna be done at the end of this. You guys can turn it up, please. Yeah.
I was addicted to fentanyl for 18 years.
I really didn't understand the kind of pain that he was going through. He'd seen at least 20-odd doctors, and one of them accused him of faking it.
I was on a lot of morphine. I remember the first time they said, okay, well, try and put that pain button aside. It was painful and it was scary and I was alone.
She was in the hospital for so long. I don't think anybody could imagine being in the hospital for a year and a half. And then Sydney got an infection, endocarditis, and ended up having to have open heart surgery.
When we started this 10 years ago, we just knew there were risk factors for people that would struggle after surgery. We had no clue what the impact was going to be. I had no idea that I'd be meeting people like Sid, like Graham, that we could impact and change their lives and give them a new life after being involved with our service.
When I first came to the transitional pain program, I was completely bedridden in the hospital on a lot of morphine, dealing day to day. Everything in my body was just shutting down due to this extreme intense pain. Mentally, physically, it just really all was affected. My condition was deteriorating over about 2 years. They were trying to really just treat me through pain meds and not treat the condition, and the pain meds became unreasonable, unmanaged properly. I would have done anything to make that stop.
What's unique about our programs is that we have really encompassed that multidisciplinary care approach early on. And so if you're struggling with a particular pain issue, we know that your mental health has to be impacted by this, and we bring that into the equation early on, not after you've been struggling for another 6 months in our program. And on top of that, we have multiple programs that we've embedded within, which then enable the patient to work on things themselves, using their own brains, using their bodies to get moving, to understand how they can de-escalate some of those opioids they've been on over time with the supports needed other than just us using the prescription pad.
9 years. 9 years ago, they figured out that dosing up people with my pain with a high dose of opiates was the wrong thing to do. 9 years. I could have, someone should have pointed me that way.
And I still had pain.
Yep.
And that was the crazy thing. And then you told me about the program, and of course I was hesitant because I didn't want to come off the stuff because I thought there'd be more pain. But, I went through with the physio and then also the psychiatrist lady, and she actually pointed out something I had never known in my entire time, that my kind of pain actually knows what the opiates is trying to do, so it just turns the volume up on the pain. After a while, we started going to the ketamine, and then when that started to work, I decided to try and take your device and get off of it. And it was the hardest thing I had ever had to do. I'm glad I did it, because it's the best thing that's ever happened to me. It's like walking out of a fog. When I finally got off of it, it's like your brain's just like, whoa, your central nervous system just comes back online, and you feel like, whoa, my God. It was like I walked out of there, and every day I woke up, it felt like I won the Masters.
Before the nerve block, I had no quality of life. I was in the hospital, I was in bed all the time, I lost friends, family grew distant. It was tough to maintain anything. It changed everything. The pain is so much less. I sleep now. Before, sleep was rare and far between. I'm rested, I can do what I want, I have my hobbies now, I hang out with friends a lot, I'm very social, so that is a really nice change for me. And I can travel a little bit, do what I want to do.
I think that the most important thing is the team approach. The entire team was very supportive of Sydney. They had a plan over the entire weekend that she would not be left hanging, ever. She lives as normal a life as she can with her condition. So she'll always have her chronic illness, but it's a completely different life. She goes out, she drives, she works. You know, it's all good.
Being a clinician scientist here at UHN has afforded me several opportunities. One is we have such a diverse clinical population. The second is I work in one of the most productive anesthesia departments in North America. You leverage the clinical and the research together with UHN's prominence and the ability to disseminate to the world, and it really was a unique opportunity that we were able to produce what we did. I think over the next 10 years, we've got a huge opportunity here. We have the opportunity to show a new model of care, continuing to increase multidisciplinary care, showing what's important, combining mental health and physical health, and the triad of care that everyone needs, regardless of the type of disease they have. Any chronic illness incorporates these three important tenets. I'd like to see this continue to expand beyond post-surgical pain into other areas of medicine and be carried on and supported by the next generation of physicians coming behind me.
So I really want to thank Graham, I want to thank Sid, I want to thank your parents, I want to thank the courageousness you had to put your stories up there and tell them for the world, and hopefully people will see that and be inspired to go on similar journeys or start their own personal journey. So we talk about the multidisciplinary team, and the team is here. And you saw Alan, Elizabeth, my fellows, and the countless fellows that have come before them, and the things that they're continuing to do. And I have the TPS in the middle of this screen because it's very egocentric, but we're not the middle. We're over on the right, and TAPME is actually the middle. But when you're in our clinic, you are in the epicenter of the pain program. And so, you know, if you're struggling with mental health, we have, you know, Andy Smith over at CAMH. Tanya Durena runs the TAPME program. You have our TRI folks that we can refer to over at Toronto Rehab. And so, you know, when you walk into these doors, there is a network of pain programs now in Toronto that we can be proud of and continue to move forward. So this is it. This is where we're going to end. And I can tell you that this is a slide that Joel also created, where we were invited to write an article for the Regional Anesthesia, the RAPM journal for the summer, to look at the last 10 years of what has happened. And you can see that if this trajectory continues, there have been over 300 publications about this concept and this service, and that line continues to increase on an annual basis. So I think we're doing something well. And so I don't know if we can prevent chronic pain, guys, but we're going to try. It's a model that we have an opportunity to do things, to do new interventions. We're starting at looking at some of our earlier interventions in terms of people in the acute setting. And if it's not possible, at least we can help people change their lives and have a little less disability as a consequence of some of these life-saving interventions and sometimes elective interventions that we do. So as these programs continue to build and continue to be created, they always continue to demonstrate value to their institutions. And one of my soapboxes, and I'll repeat it here, is every institution that is a surgically driven institution must have a service to catch that 15% of individuals that struggle as a consequence of what they do to keep them in business every day. And thank you very much. I want to acknowledge SUAP, the Ministry of Health, Grand Council Treaty 3, TAPME, of course, my department for the support that they continue to give me, the ODPRN, the best practice of surgery, and the entire transitional pain service team, from Maria, who's our front-facing first person of contact, the fellows who do all the heavy lifting, and all of the research staff. And we have so much support because of our department. Joe Carroll in particular, who's been just a pillar of managing a lot of the successes we've had, et cetera, and the entire team of coordinators, et cetera. Without you, this show stops. And so I just get to be up here and talk, but you are the heart of the program, and you are the ones who actually make this happen. And the patients obviously benefit from that. So happy to take a few questions. I don't know if I'm over time or not, K-Man, but let's see if there's anything. Okay, great. Yeah. There's a mic behind you. I don't know if you want to use it or if you just want to yell. Yeah. Okay, I can repeat it. Well, you know, there's so many layers to that question, so I'll repeat it if you didn't hear it at the back. So basically, you've got a great model here. You've got all these resources, or you've put things together. But the issue for anybody who wants to do this is, where do you get the resources, how do you get the funding, and where do you get the capacity and the manpower to do this? And so, and I'll tell you that capacity and manpower issue is front and center. When we started this program 10 years ago and we put up a posting, we would fill it within days. And now we put up a posting, and it takes some time to fill these positions because, you know, the capacity issues, and we just don't have the manpower, I think, in this country to fill some of these things. The funding part, you know, there continues to be a surplus of funding that is injected, but you can always start with the building blocks that you have in your institution, and it's really what we talk about in that downloadable document. So if you have an acute pain service and you have people who do chronic pain, you can start to connect them together, add an admin component, and then advocate for the biggest piece that's missing. If it's a psychologist, if it's a psychiatrist, if it's a an OT, a PT, whatever that piece is, to then connect the dot and then collect the data. And if you collect the data, institutions look at their data and they look at what you've done. And had we not created an REB before we actually rolled out this service, we wouldn't be here. And we had that data. We were able to show you that we saw X number of people. This is what they told us. This is what they gave us permission to tell you about that. And as much as we know we do good things as physicians, we can just talk about it. When you have the data, you can actually say, this is what we did. And so it's always, we're always so busy, but without that data, without that REB kind of component, you're stuck building something without being able to tell what you did and give that information to the world. And then beg for money. And then put in your proposals when you get the options and hopefully move things forward. No easy answer, but I think those are kind of the building blocks of that. Thanks for the question.